Let's turn our attention now to a really common activity, that of sit to stand. And these are the things that we'll cover in this clip. So first of all, I hope that you'll come away with a good understanding of why it's important to look at sit to stand and stand to sit with our patients. We'll also look at the literature and how it describes sit to stand, so the phases that it describes. And then we'll break those phases down and look at the kinematics and kinetics of a typical sit to stand movement. We'll also look at the factors that influence sit to stand, and these are called the environmental and physical determinants. And we'll finish up by looking at some of the age-related changes that can influence sit to stand. We'll do this quite briefly. So standing up and sitting down is quite a normal activity that people do many times a day. And if I ask you to just think about what you've done in your day already, and the context that you've been moving in, you've probably stood up from the bed, car, chair, maybe public transport seat, maybe you've been at a restaurant and got up from a table there. So it's likely that you've performed many sit to stand movements already and done that in lots and lots of different environments. And actually sit to stand is much harder than it looks. One of the reasons for that is the balance and postural control that's required. So if you think about, you're starting from a large, stable base of support in sitting, and then you're needing to move your body mass forward, and eventually you'll reach a position where you're actually with a smaller base of support on hopefully 2 feet than the base of support that you started with. The other reason why sit to stand is challenging is because of the muscle activity that is involved. So if you look just at what's required at the knee, the torque is actually greater than what we use in walking and stair climbing. So standing up takes a lot more muscle activity than perhaps people realise. And people that have problems with sit to stand actually find that that has a huge impact on function. So although the literature often looks at standing up for the purpose of just standing on the spot, very rarely is that why we stand up. We stand up often so that we can eventually move from one place to another, or we stand up as we're doing something else, so carrying an object. So standing up in real life is often a lot more complex than how it's studied in the literature. Being unable to stand on your own, so independently, correlates with institutionalisation in the elderly. So that definitely has relevance for our patient population. And it also has implications for acquiring and maintaining mobility in all patients actually, regardless of their age. So if you think at the other end of the lifespan spectrum of the child that can't get up from the floor, what impact does being unable to sit to stand have on that child's ability to develop the skill of learning to walk? Now, before we actually look at how to describe the sit to stand movement, I just want to discuss a little bit about the typical sit to stand, and is there such a thing? Because certainly when we're looking at the literature and the research on sit to stand, what it's looking at is starting from a nice symmetrical upright sitting posture and actually going into a very symmetrical sit to stand movement. Now in reality, those two things often don't exist. Not everybody has the ideal posture, and more importantly, we're often not standing symmetrically because we have that ability to be flexible and adaptable. So we might start with our legs crossed, or we might start with our feet being in a different position because we're standing up for the purpose of quickly turning. So just bear that in mind when you're reading the literature. It's certainly important to think about when you're thinking of your patient's treatment goals, and once they've achieved a symmetrical sit to stand, is that enough? Does it allow them to function? The other thing that I would say about the literature at this point is most of it concentrates on sit to stand rather than stand to sit. And getting down from standing is equally as important as getting up. So it's quite important that our patients learn to control getting down from standing rather than falling into a chair or collapsing into a chair. Now, the literature will describe lots of different models of sit to stand. And the good thing about those different models is that they are similar in terms of their kinematics and kinetics that they describe. The main way that they differ is in how they break the whole sit to stand movement down into different phases. They also differ in terms of the terminology that they might use for the phases, but otherwise they're exactly the same. So we're actually going to look at two now, and the first one that we'll look at is that described by Carr and Shepherd, and they actually describe the sit to stand movement according to two phases, the pre-extension phase and then the extension phase. So the pre-extension phase is largely about foot positioning, and it involves the sit to stand movement before the thighs leave the base of support. So as I just said, foot positioning is quite critical here. And the way that we determine foot positioning is if you imagine the center of the knee joint and then draw an imaginary line down to the ground, then the center of the ankle joint should be 10 to 12 centimeters behind that perpendicular line. And this is the foot positioning that allows optimal muscle activity in the lower limb extensors. Okay, so foot positioning crucial, bottom still on the chair. And phase two is the rest of the sit to stand movement. So it's from lift off until the person achieves stable stance. And another model that you might read about, and certainly it's the required reading that we gave you, is that of Schenkman. So Schenkman's model is a little bit more detailed. He actually describes the activity according to 4 phases. And actually it can be quite difficult to identify these 4 discrete phases when you're looking at the movement with the naked eye. But the advantage of Schenkman's model is because it's quite specific, that can really help you to try and identify treatment goals for your patient and actually determine which component of the sit to stand movement your patient has difficulty with. So let's go through the 4 phases in a bit more detail so you know what they each constitute. And phase 1 is called the flexion momentum phase. So this largely involves trunk and pelvic movement, and it starts when the sit to stand movement is initiated and ends just before the buttocks lift from the seat of the chair. And then we have phase 2 being the momentum transfer phase. And this involves forward displacement of the centre of gravity. And it also includes the beginning of upward movement. So it starts when the buttocks are lifted from the seat, and it ends when maximal dorsiflexion is achieved. And then phase 3 is the extension phase. So this obviously begins just after maximal dorsiflexion, and it ends when the hips are in their maximal extension. And phase 4 is the stabilisation phase, so it obviously begins when the hips are in maximal extension, and it ends when people have achieved stationary balance. Okay, so when someone has achieved quiet standing. So that was the kinematics of sit to stand according to 2 different models. Obviously Shenkman's model gives you a lot more detail. Let's look at the kinetics involved during sit to stand. And this graph shows the lower limb muscle activity. And just to orientate you to the muscle groups it represents, TA is tibialis anterior, then we have rectus femoris, biceps femoris, vastus lateralis, gastrocnemius and soleus. So if we go through those one by one. So tibialis anterior is the muscle that initiates sit to stand, and it's actually active for the longest duration in sit to stand. And through its activity, or its role really, is to stabilise the shank and the foot so that the body can move forward over that, or what's essentially going to become its new base of support. So then we have quadriceps and hamstrings, and these muscle groups activate just prior to thighs off. And the simultaneous onset of rec fem and biceps femoris actually suggests that these muscles are working together. So rec fem is assisting with hip flexion, and biceps femoris is probably acting to prevent the trunk from accelerating too far forward, and also helps to break the hip flexion. So these 2 muscles are working together. Gastroc and soleus activate at around 50% of the sit to stand movement, with soleus being active for a longer duration. And in combination with tibialis anterior, they help to provide balance eventually in standing. Now, a muscle that's not represented here is iliopsoas, and it's likely that hip flexion is initiated by iliopsoas. And as I said earlier, this is obviously only looking at lower limb muscles, but core muscles of the trunk and abdomen are going to be really important as well to stabilise and extend the trunk. So sit to stand is a whole body activity, and the translation of the body in a typical sit to stand movement is quite characteristic, and it's represented by this thing which we call the J curve. So if you imagine a marker on the acromion process of the shoulder, when viewed from laterally, this pathway is going to form a smooth J curve. Oops, too far. Sorry about that. Okay, so the marker is going to travel in quite a smooth path. Initially, it's going to be horizontal to the floor, but then as the trunk moves up, you'll see that the curve also moves up as well. And the fact that this is a continuous smooth curve actually indicates that the movement happens without a break. Okay, so that's quite important if we're talking about timing of the sit to stand movement. Okay, so we've covered a couple of things. We've looked at why sit to stand is important. We've looked at the phases. We've looked at kinematics and kinetics. Let's now look at some factors that influence the sit to stand movement. And you'll actually find that environmental, individual and task related factors will influence sit to stand. We're going to concentrate now on environmental and task characteristics. And in terms of both of those categories, we have what are called environmental and strategy related determinants. So let's look first of all at some chair related determinants. And one important consideration is this dilemma of comfort versus ease of getting out of a chair. Now, there was a study done in the 80s that actually looked at the preferences of the elderly, and they certainly ranked getting out of a chair as being the most important, then the chair height, and then coming in at third was comfort, which, perhaps for us might be almost the opposite sort of ranking. So in terms of getting out of a chair, think of how easy it is to get out of a soft, squishy sofa that you might sink into versus a chair that has quite a stable base of support and not much give. This might be high in comfort but not ease, and this might not be as comfortable but certainly probably easier to get out of. If we look at some other chair-related determinants, a really big factor is the height of the chair. Now, when we're talking about the height of the chair, you really should measure the height, taking into account the deformation of the cushion or the surface of the chair. So you'll actually find that clinicians measure the height of a chair with the person sitting in the chair. Now, the minimum recommended height or the ideal height of a chair, certainly for elderly people, is 120% of their lower leg length. And if a seat is lower than this, it certainly makes standing up much, much more difficult. Tends to increase the displacement that is needed at the trunk and the knee and the ankle, not so much the hip. Also, the moments that are required at the hip and the knee are going to be greater when standing up from a lower seat. And that also has an influence on the position of the feet, which I've already mentioned is really critical. So have a think about it, and if a chair is lower, do you think the foot position will need to be further back than normal or further forward to help somebody to stand up? And what might that mean for our patients? So starting to think about a couple of these things and how they interrelate. Some more chair-related determinants are in relation to armrests. So first of all, are they present, and do the patients use them? And another chair-related determinant is the seat angle. So if we look at armrests first of all, and if somebody uses armrests, then that's going to lower the moments needed at the hip and the knee by about 50%. So it can obviously be really helpful for somebody that is quite weak in their legs. However, how does it impact on a person's function if they're needing to push up from a chair? And is it always possible to use armrests? Think of perhaps situations where you might be sitting on something that doesn't have armrests. So Also think about our hemiplegic patients who might not have the use of both of their arms. So armrests can be useful, but not in all situations. In terms of seat angle, a seat angle that creates a posterior pelvic tilt is going to make it harder to stand up, because basically the angle means that the centre of mass is further back than is ideal. So this is really important to think of, again, when you think of how much give is in a seat, but particularly for wheelchairs in terms of the backrest, but also the seat, because just a normal wheelchair without anything fancy done to it has a lot of give in the canvas. So we've discussed a couple of chair-related determinants. Let's look at strategy-related determinants, and these are also called physical determinants. So speed is an example here, and faster speeds are going to influence up much more so than they influence forward movement. And not surprisingly, elderly subjects are less able to increase the speed of their movements than younger people. Another strategy-related determinant that I've already mentioned a few times is foot positioning. And this is really, really important because it influences how much hip flexion is required, but also how much muscular activity is required in the legs as well. So I just want you to have a think about the impact of foot positioning again on our patients, and what might be important for us to manage or treat in patients who have difficulty with sit to stand. Or another way of looking at it is if you have a patient who isn't able to stand up yet, but you're wanting to think about them being able to gain that ability down the track, what might you have to look at in your treatment program so as to keep that as an option in your treatment repertoire. And yet another strategy-related determinant is the position of the trunk. So changing the starting position of the trunk from upright to another position is going to influence the kinetics and kinematics of the whole sit to stand movement. And so when we start from a quite upright position, the extensor activity that's required is for a shorter duration, and also that's a much more efficient movement. So we get to a standing position more quickly. So again, if you apply this clinically, I want you to have a think about how seat position might influence the starting position of somebody in sitting. Also consider the person's sitting posture, and it might well be that you need to work on somebody's sitting posture and sitting balance before you look at sit to stand, or you might need to look at sitting balance in conjunction with sit to stand. And the final strategy-related determinant that we'll look at here is that of arm positioning. So there's a strong relationship between the upper body and the lower body in sit to stand. And certainly when you restrict somebody's arm movements during the standing up motion, it does lead to increased adjustments being required at the ankle. Therefore, when you're treating somebody, you'll need to think about, is it a good idea for me to restrict their arm use or not? And you'll definitely need to think about it in the context of your treatment goals. There might be occasions where you actually want to restrict their arm use, and other occasions where it's entirely appropriate for them to use their arms. And finally, let's look at age-related changes. And so these are the individual factors which are influenced by the aging process. And it's actually unclear if age-related changes are due to muscle force, balance disturbances, neuromusculoskeletal changes, or altered motor control, or actually a combination of all of these things. And so that's why really careful assessment of each and every patient is important to work out exactly what's at play in your patient. Sit to stand is essentially a task that requires balance and postural control. So you should also be assessing all of the various systems that contribute to balance as well. And lots of our patients actually use their arms during sit to stand, and it's highly probable that this is because it's a strategy to help with their balance. So always think about somebody's balance ability when you're looking at sit to stand as well. So what I hope that you can take from this clip is the following: that you'll appreciate that you need to have a good understanding of the kinematics and kinetics when analysing sit to stand, and that there are many factors that influence sit to stand, and they're broadly classed as the environmental and physical determinants. And you'll also need to take into account lifespan issues, and we've touched on just a few of them in relation to the elderly.